Good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who is interested to attend. Today, we will be talking about Enhanced Barrier Precautions, or EBP. Everyone has entered this meeting on mute, but we will have a discussion at the end of this webinar. So if you have any questions or comments, please submit them to us using either the chat or the Q&A tools in your Zoom menu. We encourage you to join us every Wednesday at 2 p.m. for more of our weekly webinars. Next week, we will be discussing CMS's critical element pathways for infection control. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. And now I'd like to introduce our guest today, Cindy Wanling. Cindy began her nursing career in 1982 as a certified nursing assistant at a long-term care psychiatric center. Since becoming a registered nurse, she has covered a multitude of specialties, but eventually returned to her first love, the long-term care population. She has served as director of nursing, clinical consultant, director of clinical operations, and VP of clinical quality and operations. In recent years, her specialty has been regulatory compliance, overseeing 60 facilities covering 6 states. Cindy joined the Quality Insights team in July this year, continuing her career-long goal to ensure long-term care populations receive the best possible care. So Cindy, welcome, and thank you for joining us today.
Thank you, Kathy. It's good to be here, and welcome everyone. We're going to talk about a very popular or a very talked about topic today, the enhanced barrier precautions. As I told Kathy prior to the presentation, that there may be questions that I can't answer for you, but we'll certainly take those questions and dig into the details. This information was obtained through a variety of resources, and we're going to touch those resources at the end of the presentation. So the objectives for today's presentation is just a brief historical overview of multidrug-resistant organisms, or MDROs, or MDROs, however you pronounce them in your area. What is the cause? What is the spread? It will be brief because I imagine the majority of the folks on here have a great understanding, and it's here for you to use with your staff. The Centers for Disease Control will be our focus and their rationale for recommending the enhanced barrier precautions, as well as the general guidelines for implementation. So let's talk about the MDROs. What are the causes of MDROs and what are they? They're multi-drug-resistant organisms are bacteria that have become resistant to certain antibiotics. And we're all familiar with that, but there's a whole new crew of nurses and frontline caregivers that have come into our care settings in the last 2.5 years, and they're so familiar with COVID. So these are good reminders for our teams. MDROs have been around since the 1940s and were first identified as a penicillin-resistant staph. And the widespread use of these particular antibiotics have created where we are today with the MDROs. So, what is the cause, the spread, colonization, infection, and who is at risk? Again, it's the overuse of antibiotics in the majority of the instances. And how are they spread? They're spread from patient to patient and on the hands of healthcare givers. They can also be spread by the objects from person to person and through direct contact. So what is colonization? I think we all know the colonization historic MDRO that is in our system or can be in one system, not causing an active infection. And colonization rarely becomes an infection unless the bacteria spreads to a part of the body where the bacteria are not usually found. So what is an infection? An infection means the bacteria are in or on your body and causing illness or other medical conditions. And who is most at risk? We think about children, young children, the elderly, and people who have immunocompromised situations, and people with the chronic conditions of the lung, heart, and kidney are at the greatest risk to develop an actual MDRO infection. So let's talk about the rationale of the enhanced barrier precautions. According to the CDC, residents in nursing homes are at an increased risk of becoming colonized and developing infection with MDROs. More than 50% of nursing home residents may already be colonized with MDROs. Focusing only on patients with an active infection fails to address continued risk of transmission. So obviously the concern is we know we have our line listings who has an MDRO who is colonized, but if we focus only on those individuals, the concern of the CDC is that we will continue to spread within the nursing home setting. And there is growing evidence that traditional implementation of contact precautions in nursing home is not implementable for most residents with the prevention of the MDRO. So the rationale is really to thus enhance barrier precautions and to particularly focus on novel and targeted. That was the original rationale with CDC, and they went on to expand that we want to also include the epidemiological important MDROs as well. So just a little chart to break down what are the novel targeted. And I'm not going to try to pronounce all of those. I'll let you take a stab at your own screen, as well as the ones we're more familiar with, the MRSAs, the SBLs, the VREs, and the drug-resistant strep. Now, the guidelines for implementation of enhanced barrier precautions, it's really expanded use, or again, enhanced use of PPE, and it refers to the use of gown and glove in circumstances, and in particular, high contact resident care activities that have the opportunity to transfer the MDRO from the staff's hands and clothing. So MDROs may be indirectly transferred from resident to resident during these high contact care activities. Nursing home residents with wounds and indwelling medical devices are especially at risk of both and colonization with MDROs. So again, to reiterate, and Kathy is such a huge help with us when we pull these presentations together. I said, I'll leave my red in red because we need to remember significantly the importance of high contact resident care activities. So the use of glove and gowns in those activities is when contact precautions do not otherwise apply. For nursing home residents with wounds and or indwelling medical devices, regardless of their MDRO colonization, as well as for residents with MDRO. And we'll talk about that, split it up in a little more detail here in just a second. So let's talk about our high contact care activities. These are specifically and directly from CDC. You'll notice that in our resources. So examples of high contact resident care activities requiring a gown and gloves used for enhanced barrier precautions include when you're dressing a patient, a resident, when you're bathing or showering the resident, when you're transferring the resident, when you're providing hygiene. And this hygiene includes brushing their teeth, combing their hair, and shaving them. When you're changing their linens, when you're changing briefs or assisting with toileting, when you're providing device care or use of the device, examples, central line, urinary catheter, feeding tubes, tracheostomies, ventilators, and when you're providing wound cares. And we're going to refer to the CDC's frequently asked questions. I obtained that particular information from that website. And again, it's in resources. And when physical and occupational therapy are being provided. So let's talk about the chronic wounds and the indwelling medical devices. The chronic wounds and the indwelling medical devices are means in which a person would most probably obtain MDRO infection. It's the generally included in residents with chronic wounds and not those with only shorter lasting wounds, such as skin breaks or skin tears covered with a bandage or similar dressing. My positions historically bring me pause. I think, again, it would be at the center level to look at the particular wound you're providing, how much care is provided for that particular wound, and how much direct skin-to-skin or person-to-person contact will occur regardless of the time of the wound care. Examples of the chronic wounds that's provided by the CDC include, but are not limited to, the pressure ulcer, your diabetic foot ulcers, your unhealed surgical wounds, and your chronic venous stasis ulcers. The indwelling medical devices for enhanced barrier precautions are central vascular lines, including hemodialysis catheters, urinary indwelling catheters, feeding tubes, and tracheostomy tubes. So things to consider about an EBP. It's simply that, enhancing the current standard and transmission-based precautions. Gowns and gloves are to be used for each resident during high contact resident cares activity, should be removed after each resident encounter. Hand hygiene should be performed, and new gown and gloves should be donned before caring for a different resident. And again, anyone in healthcare for an extended period of time, you look at that and you think, well, what's unusual about that? But you have to remember about some of the different circumstances that we've all experienced over the years of COVID. EBP is not recommended for residents with C. diff. With C. diff, you continue contact isolation and precautions. These residents do not require a private room and are not restricted to their room. More things to consider: intended to be in place for the durations of the patient's stay in the facility or until resolution of a wound or discontinuation of an indwelling medical device that placed them at higher risk. So if the person does not have an MDRO colonization or an MDRO infection, then once their indwelling device is removed or their wound is healed, they no longer need to be in EBP. If they are colonized and have a history of infection, then they would continue EBP for the duration of their stay. So intended for MDROs and not replace existing guidance regarding use of contact precautions is an important reminder. Enhanced barrier precautions are primarily intended to apply to care that occurs within the resident's rooms, where high contact resident care activities, including transfers, are bundled together with other high contact activity, such as part of morning or evening care. Does the patient require a private room? No. Single person rooms, if available, should be prioritized for residents who have acute infection with a communicable disease, or for residents placed on contact precautions for presence of acute diarrhea, draining wounds, or other sites or secretions that are unable to be contained. So shared rooms, you will have people in shared rooms, and this always creates some issues at times, some challenges in our centers when we have shared rooms. Residents on enhanced barrier precautions may share rooms with residents. Facilities with the capacity to offer single person rooms or create roommate pairs based on MDRO colonization may choose to do so. If there are multiple residents with novel or targeted MDROs in the same facility, consider cohorting them together in one wing or unit to decrease the potential spread. When they are in a shared room and a single is not available, you cohort patients with the same MDRO in the same room or patient care area. When cohorting patients with the same MDRO is not possible, place MDRO patients in rooms with patients who are at low risk for acquisition of MDROs and associated adverse outcomes from infection and are likely to have short-term stays. So an example of this would be no open wounds, no invasive medical devices, no one who is immunocompromised. When you have roommates, one thing that must happen with enhanced barrier precautions is you maintain spatial separation of at least 3 feet between beds, use privacy curtains to limit direct contact, clean and disinfect any shared reusable equipment, clean and disinfect environmental surfaces on a more frequent basis than you would ordinarily do, change personal protective equipment if worn. Again, remember, you may have someone who has colonized or infection with someone who is not compromised. Perform hand hygiene when switching care from one roommate to another. So what about the signs? That's maybe one of the most asked questions is, what about all these enhanced barrier precaution signs? Because you remember, these need to be posted with people who are colonized or infected, and those who have the medically indwelling devices or chronic wounds. So there are a lot of signs. So let's see what the CDC has to say about the signage. Signs are intended to signal individuals entering the room with specific actions they should take to protect themselves and the resident. To do this effectively, the sign must contain information about the type of precautions and the recommended PPE to be worn when caring for the resident. Generic signs that instruct individuals to speak to the nurse are not adequate to ensure precautions are followed. Signs should not include information about the resident's diagnosis or the reason for precautions. And inclusion of the diagnosis or the reason for precautions would violate HIPAA and resident dignity. So I think we're at the point where you can ask questions. We have my contact information up here, and Kathy goes into all that after the presentation about how you get this information. But one thing that I titled a resource is usually it says resources. And I have found with Enhanced Barrier Precautions, it's really, really important to know your resources. Most of you know that the CDC page was updated in July of this year. It could be updated again. So it's really significant that we know where these resources are and that you have the links. So I thank you for your time this afternoon. Kathy, do we have any questions?
All right, yes, we do have a question. And if anyone else has any questions, please submit them to us using the either the chat or the Q&A tool. So this question says, my folks are confused about total assist feeding. That task isn't listed as one that would require EBP, but I feel like you're actually likely to touch a resident at some point, wiping the mouth, etc.
I have to agree with your statement. To me, that I think the center would have to go back. Remember, a couple slides back, it says specifically events that happen in the patient's room. When you go to the frequently asked questions page on the CDC, there is a question that asks, what about in the dining room? And there's an example given. If I am Kathy's nurse today, and Kathy is in her room, and I'm transferring Kathy in her room from her bed to her wheelchair, the gloves and the gown to perform that transfer. If Kathy is in the dining room and she needs transferred from her wheelchair to her dining room chair, it is not required that I don the PPE to do the transfer. Again, that's why it's so important that organizations and centers look at what they're doing in their centers to ensure that you meet the needs of your patients and become very CDC website and the frequently asked questions.
All right, so the next person asked for a link to the sign that you shared, and I just pulled that up and I just now dropped that in the chat. So I was also going to say, afterward, later on this week, I'll be emailing everyone who registered for this webinar with the recording of this email and this slide deck. So all these links will be in the slide deck if people want to be able to get it that way. And let's see, I think we might have another one. No, that one's done. Okay, well, we still have a little bit more time here. We had one more thing we wanted to share with you, but in the meantime, if anyone does have any questions, go ahead and start putting those in the chat. And Cindy, if you're ready, we can share these tools that you made based on all this CDC guidance. So if you're ready, I can go ahead and share my screen and we can look at those real quick.
Sure, I've stopped sharing.
Okay. Here are the tools that we've been working on. These will be available in the coming days. We're just doing a little finessing with them. So Cindy made these tools based on the CDC guidance. You can see one is an evaluation tool for residents, and the other one is just a general safety audit. And they're checklists, so you can go through and do assessments. Did you want to talk, go ahead and talk about your tool, Cindy, how to use them?
Just briefly. Kathy, this is something, and I don't know if Jennifer's on. Jennifer Brown is our infection preventionist, and she and the nursing home team as well take a look at these and give recommendations. And so I think those people, it's not just a me thing, but With that said, with the enhanced barrier precautions resident evaluation tool, I really didn't know if centers would find purpose in this, but given the strict guidance of the CDC guidelines, how it was put together is that when you have a patient or resident admitted to your center, if they have a diagnosis, it's covered here, the pre-evaluation when they come to your center, so you'll know what to do. And then do they have, or are they colonized with an MDRO? Also, do they have the devices in place? Do they have the chronic wounds in place as defined by the CDC? And then a checklist that goes down through what is defined as the high care area activities. And there's a little reminder at the bottom that is your signage there, and has your care plan and your staff documentation been updated, so everyone in the center knows when to apply the EBPs. So we hope you find these useful, and we will be sharing them with you.
Yeah, we'll be including links to these in that follow-up email with all the resources. So we have another question here.
Okay.
It says, we have a lot of concerns about how this is a resident-centered care. This is their home requiring PPE every time they're transferred. Does not seem very resident-centered. And I think, did I stop sharing my screen?
I think you're still sharing.
I'm going to stop sharing. Well, I don't know how. Okay, sorry.
Oh, you do know how.
No, oh, here we go. They Zoom hid the tool from me. Sorry.
That is a question that I think that each center and each organization needs to reflect on, and not something that can be easily answered. Again, we're here to share the CDC guidance on enhanced barrier precautions and not dictate how care is provided at the center. One recommendation that is very common is be sure that if you've implemented EBPs at your center, that you are following your policy based on those particular policies and the recommendations of the CDC. And I wish I could respond more in depth, but that's not a decision that we can make as an outside agency, or even a referral.
Yeah, and if I can just add something, Cindy, and I think something to think about with resident-centered care, person-centered care, is occasionally something will come up where even if you're in your home and you have an infection or an illness, you take extra precautions. So sometimes you can relate that to if the resident has an MDRO and they have an infection or a wound or something, to think of when you're talking to them about it, like, this is why we might need to use this extra precaution at this time. So I would talk about that, around that person-centered care. And maybe that would help a little bit with the understanding of, this is why we have to be a little bit more careful now. It's no different than if you were in your home and you had something like that. So that's just a thought. I mean, like I said, we give you the resources, and we do want you to look over them. But that is something that I know when I worked with residents and families, that's sort of how I would relate that to help with that person-centered care.
Thanks, Penny. For those of you who haven't been on our calls before, Penny Imes is the head of our nursing home team.
And Kathy, Penny, I want to thank you for that comment. On your resources page, there is a link to the CDC, and there are two letters. One is for the patient, the other is for the family, to explain enhanced barrier precautions. And the letters actually do a very good job. So that link is provided to you as well.
Got another question if you're ready for the next one. It says, a healed A/V dialysis graft, would this count alone as a reason for EBP to start?
It's healed and no longer requires treatment. It's healed and approximated, and there's not even a millimeter open anywhere. If it's completely healed and the person does not have colonization or an MDRO, then they should not require enhanced barrier precautions. But I would make sure it was completely healed.
Okay. So that's all the open questions for now. If anyone wants to ask a question, if say like you're not comfortable with the Q&A tool or the chat, you can also raise your hand and we can invite you to unmute yourself and you can ask your question. So that's just a third option if anybody would rather just speak their question. So I'll take a minute to go over a couple of our closing items. And during that time, if anyone has any last moment questions, you can send them to us again using the chat, the Q&A tool, or raise your hands. Okay. So again, I'd like to invite everyone to next week's webinar, where we will be discussing CMS's critical element pathways for infection prevention, which will be next Wednesday at 2 p.m. And if you want to talk further on these topics, but prefer one-on-one discussion, we invite you to join us during our office hours, which are each Tuesday at 8 a.m. and each Thursday at 2 p.m. The office hours are kind of like a chat room, but they're live and you can drop by and someone on our team will be there to answer your questions. And you can find the links to those live chats and all of our webinars in the newsletter that we send out each Friday called the Last Minute Lowdown. If you would like to receive that newsletter, but don't think you're on the mailing list, you can email me at caudill@qualityinsights.org and I will get you on that list. And I will also drop my email in the chat here shortly, along with Cindy's email in case you'd like to contact Cindy, which is cwandling@qualityinsights.org. And we got one more question. So I'm going to drop this in real quick and answer this question. Actually, I'll drop it in after you answer the question, Cindy. The question is, I'm seeing very little difference between contact precautions and EBP. Can you explain the difference?
The primary difference is the isolation piece and the care you're providing that is specifically outlined by the CDC. You know, contact precautions are you don and doff because of the contact precautions and at all times. With EBPs, you're donning and doffing while providing certain care, such as the indwelling, medical devices, and then when you're providing the high, what is determined or qualified to be the high activity care areas. So that is really the distinct difference, and they are not isolated. People who are on EBP only are not in any type of isolation.
Okay, that's our last question for now. I don't see anything else in the chat. The chat now has my email and Cindy's email. And if anybody is listening to a recorded version of this later, I will also provide links to the slide deck so that you can access all those resources in the slide deck that Cindy had. And I think we're ready to wrap up. So again, I'd like to thank everyone who came today. If you need to contact me, my email is caudill@qualityinsights.org. I can help with the newsletter, or if you don't receive the recording from me for whatever reason, maybe your email filters me out, you can reach out to me directly, but I'll be sending that email later this week, either Thursday or Friday. And you can contact Cindy at cwandling@qualityinsights.org. And I think we can go ahead and sign off here. Thank everyone for coming and hope to see you again next week. Have a good day.
Thank you.
Thanks, Cindy.